Welcome everybody. It's an absolute delight and privilege to see you all here on this lovely Mancunian morning. About our fair city until I spent the best part of 2 hours on that glorious circular car park we call the M60, and I've run out of nice things to say about Manchester now, but maybe I'll think of some more as the day goes on. So my name's Roger Prudham. I'm going to kind of MC the event today, and our intention in bringing this together was for this to be a whole system event. So we wanted to include as many people from the community who look after or have responsibility for patients with colorectal cancer across Greater Manchester, and thematically we wanted to represent some education, showcase some of the innovation that's taking place right from the beginning in terms of patient awareness, in terms of epidemiology, right through to some of the cutting edge treatments and through to best supportive care as well, reflecting the whole journey that we may go on with a diagnosis of colorectal cancer. And I've got some boring things to do in respect of housekeeping. There is no fire alarm that's planned for today, so if you do hear an alarm, there are fire exits at the back of the hall there, behind you on that side, and on the other side as well. And the muster point is the far end of the car park, if that transpires. Toilets are located on the same floor of this event, and it says here, just run right out of the main hall. So if you're going to the toilet, you've got to run, okay? So if you're walking, I know you're going off to have a fag. If you're running, we know you're going to the toilet. Sorry, Rachel, I don't know why you put that, but there you go. We've got some great resources to use. The agenda and additional resources can be accessed by scanning the QR code on the table. And I think the other thing that the QR code will do is it will lead you to the tree that lists a whole load of resources that you can use to inform yourself better about some of the aspects of colorectal cancer we're going to talk about today. I want to say a huge thank you to our sponsors, Norgine and Surgees. Please spend some time when you can having a chat with them. There are many of us in this room who know an awful lot about movie prep and Plenview and other things that can go up your bottom. But for those that don't, have a chat with Norgine and Surgees, and they'll enlighten you. Any dietary or accessibility requests that you haven't already informed us about, please just let the team know. Speak to a member of the Academy team. They're friendly and they're easy to identify. You've all got the Wi-Fi code, I should hope. Those of you who engage with social media on a regular basis, please use the hashtag, all capital letters, GMCA24 when tweeting about the event or I should say when Xing about the event on the platform that was formerly known as Twitter. Just to let everybody know, the event is going to be recorded and will be available to be viewed on demand. So if there are bits of the of today that just pass you by a little bit, you can catch up on them later. But importantly, other folk who haven't had the opportunity to come here today are going to be able to see that as well. This is the first colorectal specific event that we've had for some time. It's by far the biggest that we've had in Greater Manchester as a colorectal community, and we've had over 130 people register to come, and I'm sure some people who haven't been quite as creative with their shortcuts and aggressive driving as I was to get here might come in a little bit later over the course of the morning. Importantly, also, we've got contributions from patients, and the rules around having a sponsored meeting with industry sponsorship are we can't have patients in the room in person, but we've got our patients here in spirit, and that's reflected in some of the fabulous art that's to the left, but in terms of some of the paintings and images, but also art in terms of poetry. And the poetry isn't specific to colorectal cancer, but it is written by cancer patients, reflecting their experiences and feelings about cancer. Those were all written at the Maggie's Centre in Manchester, and represent the work and thoughts of those patients, and are really quite touching. The book is available in all GM libraries, I feel like I'm on a chat show now. I've got my book out. It was published to accompany the Science Museum's world first exhibition, Cancer Revolution, Science, Innovation and Hope. So I'd like to thank all of those who've generously shared their work with us, both in terms of the art and the poetry too. The details for all of this are in the link tree, which is on the QR code on your table. So I'd like to begin the event with one of those poems, which it's so apposite to do this today. We've had World Cancer Day on Sunday, and of course there is nothing but cancer in the news today, following the King sharing his recent diagnosis, and so we've got no better platform to increase awareness, engagement, and perhaps some courage in terms of people coming forward, sharing their stories, sharing their symptoms. And getting themselves seen by all of you guys as soon as symptoms might develop. So I just want to open proceedings with this poem by Julie Colver, which is called A Beginner's Guide to Diagnosis. Learn to read the faces of the experts, doctors, consultants, nurses, specialists. It's a secret code, forged in special classrooms. A secret society, not easy to crack. Learn that the soft-eyed look betrays much. The forerunner of, I'm afraid it's not good news. I'm sorry to have to tell you. Alongside name, date of birth, first line of your address. Learn to go inside yourself. Creep into a secret place. Wrap yourself with a soft blanket of oblivion. News whipped. Only come out when they've gone. Thanks, Julie, for that, and some great thoughts there. So I want to open the first session and introduce Dr. Steve Knight. Steve, do you want to come to the stage, and I'll get you to introduce yourself, and we're going to, in a moment, have a patient story as well. Thanks, Steve.
Thanks so much. Morning, everybody. My name's Steve Knight, and I'm Deputy Chief Medical Officer of NHS Greater Manchester, and it's a real privilege to be part of the event here today. We're going to open the session today, continuing the theme of our patient voice, and we're going to have a short video which has been done by a gentleman called Brian Stott. Brian's a patient representative, and he is a former bowel cancer patient, and he was diagnosed via the bowel cancer screening program during the COVID pandemic. Since his diagnosis, he's joined the Greater Manchester Cancer Voices community as a patient representative, and he's worked very closely with that group to make improvements to the patient experience. He's a member of the Colorectal Cancer Small Community Group. He's a representative on the Alliance's Cancer Board, and he has recently helped to judge the Greater Manchester Cancer Awards in 2020. And here is a short video of him talking about his cancer journey from his fit test through to recovery.
I got a fit test through the post. It was the second one I'd had. I had one 2 or 3 years earlier. So I followed the instructions, did what it said, put it in the post thinking I'd get a letter like last time saying, everything's okay, away you go. And I got a letter saying that there was something on it they didn't like the look of. And so they made an appointment for me to have a colonoscopy and a closer look. Well, I got the appointment and went to Rochdale Infirmary, and they did the colonoscopy, and the surgeon was the head man, and he said, we'll send it off for histology, but there is a tumour there, and I know from my experience that it is malignant, and so we're going to have further treatment. I had no symptoms, I had no loss of appetite, had no bleeding, I had no loss of weight. I was still doing everything I normally did, and it was a complete and total shock. I had blood tests and a CT scan, and then I had an appointment with the surgeon where he explained what they were going to do, and they said, this is the treatment plan. This is what we're going to do. We're going to take this out, put it back together again. We should get it back together, but you may have to have a stoma, which they explained all what that was. And they said, you booked in for Thursday. So from the first endoscopy to the surgery was less than 3 weeks. I had the surgery done, then I was in hospital for 3 days, and everything had gone okay. And I came home, I went in on the Tuesday, came home on the Friday with a handful of medication and injections and swabs and plasters, and it was then a case of recover. Then about a fortnight later, we got a phone call from the colorectal team who said that they'd taken 27 lymph nodes, they'd done histology on them, and there was no sign that it had spread to anywhere. And they were quite happy with what they'd done. There'd be no chemotherapy, it was just get over the operation. I've always been very active. I used to play rugby. When I finished playing rugby, I became a rugby referee. I used to run marathons in the summer just to keep myself in shape. And I think that all that has stood me in good stead. I think doing the fit test is extremely important. It took me 5 minutes, and that 5 minutes definitely saved my life.
So it's really crucially important that we hear the patient voice, and I think when people like Brian contribute their time and their energy to help improving patient care, I think it's something we can all be really, really grateful for. So I'm going to now introduce the first session of the day. We've got 2 excellent talks. What we will do is we'll have both presentations, and then we'll have a question and answer session at the end of the second talk. It's World Cancer Week at the moment, and the theme of this year's World Cancer Week is closing the gap. So it's really appropriate that our first talk of the day is about the epidemiology of colorectal cancer. I'd like to introduce Alison Pye, who is consultant in public health for NHS Greater Manchester, and Ben Fryer, who's a consultant in public health for Stockport, and they're going to tell us about the epidemiology of colorectal cancer. Thank you.
Thanks, Steve, and hi, everybody. Can move the slides on with this, can't I? There we go. I'm just going to make a start on things today. So I'm just going to start by giving a bit of context in terms of the background of health and health inequalities in Greater Manchester, and cancer and colorectal cancer within that. And then we're going to take you on a bit of a journey with the data through the patient journey. So from incidence of colorectal cancer through to early diagnosis and screening. And then I'm going to hand over to Ben, who's going to talk about the care pathways once people are in the system, and then mortality and survival. And then we've posed a few thoughts on discussion questions for the end of the session. So without further ado, I'll start off, as I say, with just providing a bit of context to this. So we all know that Greater Manchester is a fantastic place to live and work, but there are significant inequalities. So we know that 40% of our population live in the 20% most deprived areas of the UK. 1 in 4 of our children and young people live in poverty. And there's unemployment rates are significantly higher than the England average. And as a result, our citizens, the people that live in Greater Manchester, get ill earlier, they spend more of their lives in poor health, and they die earlier than the national average. And within Greater Manchester, we know there's also inequalities in health. So between local authority areas, if you, for example, live in Manchester, or if you're a male born in Manchester, you can expect to live on average 5 years less than a male born in Trafford. And that difference is even wider when we think about healthy life expectancy. That difference actually extends to about 10 years between local authority areas. And within local authority areas, actually that difference is much greater, up to 20 years, sometimes in terms of that difference of how long people can expect to live in good health. And cancer, and within that colorectal cancer is a big driver of some of those health inequalities. So we can see in the chart on the left-hand side that in Greater Manchester, cancer accounts for about 15% of that difference in life expectancy between the most and the least deprived areas in Greater Manchester, which is a huge amount, second only behind cardiovascular disease. And from our national data, which is on the right, we know that lung cancer and colorectal cancer probably play the biggest part within that cancer bucket. So nationally, colorectal cancer accounts for about 1% of that difference in life expectancy between the most and least deprived populations, which is actually a significant amount for one disease. And we'll talk a bit about some of the reasons for that in the coming slides. But really important to say at this point that these inequalities aren't inevitable, they're entirely unjust, unfair, and they're avoidable. And when we think about avoidable mortality and morbidity, we know that, I'm sure people in the room know that over half of cases of colorectal cancer can be attributed to so-called behavioural risk factors, so 54% in fact, so things like poor diet, obesity, overweight, and lack of exercise or excess alcohol. So there's actually a significant amount that we can do to prevent cases of colorectal cancer and to reduce people's risk, individual risk of developing it. But actually, if we focus specifically just on those behavioural risk factors, we're missing that wider picture. So when we think about preventing cases or reducing the risk of colorectal cancer, we need to look past those behavioural risk factors at the causes of the causes, so the social and commercial determinants of health, so people's housing, their employment, their income, the things that really affect their ability to adopt a healthy lifestyle or behaviours and to access things like healthy food and green spaces for exercise, but also the things that affect their ability to access health and care services. So if I just move on now, so I guess thinking about the fact that over half of our cases of colorectal cancer are preventable, it's worth then talking about the incidence. So if we look on the chart on the left-hand side there, that's our national data, and that's back in from 2021, that's the most recent data we have. And we can see that for the first time actually this century, the number of bowel cancer registrations was higher than the number of lung cancer registrations, which means that it's now the third most common cause of cancer in England. We also know that it's more common in men, and actually the second most common cause of cancer in men after prostate cancer. But if we think about the incidence rates, which is the chart on the right-hand side, which helps us to track rates over trends over time, we can see that actually up until about 2019, our incidence rates in both males and females were relatively stable up until, as I say, 2019, when there was a 10% reduction in incidence rates in both men and women. And that obviously aligns with the disruption caused by the COVID-19 pandemic and actually aligns with the trends across other cancer types. So I think it'd be really interesting when we get our new data to see what that trend's looking like post-pandemic. But those national incidence rates really mask variation in incidence by place and by different groups. So the chart on the top left-hand side shows incidence rates across Greater Manchester in all 10 of our local authority areas compared to the England average. And we can see there that the rates in incidence rates in Tameside, Bolton and Stockport are significantly higher than the England average. In fact, in Tameside, about 10% higher than the England average. And the causes for that obviously need unpicking, they're obviously multifactorial. One of the factors could be, certainly for Tameside, we know that there's particularly high levels of smoking prevalence and obesity and overweight in adults. We'll come on to this in the next slide, but there's also something about the mix of ethnic groups in those different locality areas. And we can see in the bottom chart that incidence rates also vary by area deprivation. So that's particularly important, it seems, for men. So the data in those charts at the bottom is Greater Manchester data. We can see that for people living in the most deprived areas, their incidence rates of colorectal cancer are significantly higher, at least for men, compared to those people living in the least deprived areas. And that's similar to our national data. So when we think about, as I say, ethnicity, colorectal cancer incidence by ethnicity, actually the local and national data is much less available when we want to look at this, but this is from a study back in 2022 published in the British Journal of Cancer, where they looked at incidence rates across different ethnicities in a range of different cancers. And this is just a snippet of those results, but you can see here that similar to many other cancers, the incidence of bowel cancer is actually lower, significantly lower in non-white minority ethnic groups compared to white ethnic groups. And again, the reasons for that will be multifactorial. Some of that will be what we call the healthy migrant effect. So migrants coming from other countries tending to be healthier than the general population that they're sort of joining, but also the so-called linked to sort of so-called Western lifestyle. So we know that things like smoking and prevalence and obesity are lower in some ethnic minority groups. So that's all we were going to say about incidence. Moving on now to early diagnosis and screening, which we all know is massively important in terms of prognosis and the implications for morbidity and mortality. So the chart on the left-hand side just shows incidence rates over time. Sorry, start again. The chart doesn't show incidence rates. The chart on the left shows the proportion of people diagnosed at an early stage. So that's either stage 1 or 2 for colorectal cancer in Greater Manchester. So that's the red line, and the black line is the UK. And that shows the trend between 2013 and, I can't read it, 2021. And we can see that up until the pandemic, so just in 2019 there, we can see the incidence rate, the proportion of people diagnosed at an early stage was relatively stable until the pandemic, when we saw a significant reduction in the proportion of people diagnosed at an early stage. But that reduction actually does seem to be deeper and steeper within Greater Manchester. Reassuringly, we can see that post-pandemic, the proportion of people diagnosed early is increasing again, both nationally and Greater Manchester, but we're well under the 75% target set nationally for early diagnosis, and certainly in GM as a whole, and in all 10 of our local authority areas, we're significantly lower than the national average. So lots of work to do relating to early diagnosis. And when we break those figures down by deprivation, we see a sort of familiar picture. So the bars on the left-hand side are represent our most deprived areas. This is England data, and the bars on the right are sort of least deprived areas. And we can see that the proportion of people diagnosed at a late stage, so stages 3 and 4, that's our red and yellow boxes, is higher in our most deprived areas compared to our least deprived areas. And there's probably, again, many different reasons for that. We know, which we'll come on to in the coming slides, that people living in more deprived areas are less likely to access screening, but they're also less likely to recognise the signs and symptoms of early disease, and they're also more likely to report barriers in access to services, even if they do recognise new symptoms. So just talking about screening before I hand over to Ben, which is obviously a really important part of that early diagnosis picture. So this is data on our coverage and uptake of bowel cancer screening across GM and compared to England. So we can see in terms of our coverage rates, we are happily achieving our 60% target of screening coverage uptake across GM and in all our local authority areas. And that uptake is increasing. But you can see from the chart that in terms of both coverage and uptake, we are across GM as a whole, and in all but 3 of our local authority areas, our uptake and coverage is lower than the national average. So again, work to do to try and improve that uptake. And we don't have, at the moment, data on inequalities for GM relating to our screening uptake. That is coming really soon, which will be really useful in terms of targeting and some of that work we need to do. So this is national data, but again, we see that similar picture where actually our uptake for screening, bowel cancer screening, is lowest in our most deprived areas, particularly in men, and also in our areas where there's a higher proportion of non-white ethnic minority groups. So as I say, significant amount of work, and we've just done some really interesting, actually some of you might have seen some really interesting insights work in GM, looking at some of the potential reasons behind some of these inequalities, which will help inform some of our work. But I'll hand over now to Ben, who's just going to take you through some of the data on care pathways.
If I just recap for 10 seconds, what we've seen so far is inequality at every stage of this pathway, whether it's by ethnicity or by deprivation, which is probably the biggest inequality, but we're also seeing a really important inequality by sex or gender as well. So there's kind of this building picture across the different things we've looked at of inequality at every stage. And to give you a little bit of a spoiler, that's going to continue over the next few slides. There's a lot going on in this particular slide, but starting with the one at the top left, what that's showing is that by deprivation, there's what looks like for the first 8 deprivation deciles, the first 80% by income level, you're seeing a gradient with the lowest numbers heading upwards as deprivation increases. Sorry, got that the right way around. We see the highest levels of referral at the lowest level of deprivation, but there's a kind of slightly weird effect at the bottom there. Looking at referrals by locality, the referrals aren't consistent, they're not even. There's a lot of variation in practice across Greater Manchester, and we don't know whether that's the public coming forward or different consultation experiences when people come to GP surgeries. But if we compare the incidence data earlier, what we would expect is that you'd see referrals roughly mirroring incidence. And we don't see that. What we see in Bolton in particular, but Bolton's not alone, is a considerably lower rate of referrals for an area that actually has reasonably high incidence. We see the biggest inequality in referrals by gender or sex. So we see considerably lower referrals per case found in men than in women. So we are clearly not seeing the level of referrals for men for investigations for bowel cancer that we should be seeing, and there's a really big inequality there. We need to understand that. The final thing on this slide is the data on route of referral, and I think this is probably a familiar picture to many of us. We see most of the referrals through either two-week wait pathway or through emergency presentation. Those are the two main routes, but we also see other GP referrals and some referrals through screening. But in the least deprived population, we see a greater number through screening, and we see a greater number through the two-week wait pathway. In the most deprived population, we see emergency presentation dominating. So what that means is, in our population in which we see the highest incidence of cancer, our most deprived population, we're picking up a larger proportion of those through emergency presentation, and inevitably, through emergency presentation, it also means we're picking those up much later than we would like to. There's a lot of data going on in this slide, and I'm not going to go into this one in as much detail. This slide is an attempt to show the data on waiting lists and referral to treatment times, looking at different localities and looking at different deprivation levels for population groups across Greater Manchester. One of the things that we've seen in this data post-pandemic is that it looks like at this level we have greater equality by deprivation than we had before the pandemic, but that's a mistake to read the data in that way. Because what's happened is our waits have got so long that the cut-off of the target no longer is at the level where the inequality appears. And if you look at our most deprived population groups and the total amount of time they spend waiting, what you'll see is that there is about a 3 to 4 day longer wait on average for our more deprived groups. It's just that you see that in the very long tail of the longest waiters, rather than seeing it at the kind of midpoint, which is where the target is at the moment. So I'm sure you'll cover mortality and treatment outcomes in more detail throughout the rest of the day, but I wanted to make sure that we covered it at least briefly within this presentation. What we're seeing within these charts is a positive picture, a trend of falling mortality over time. But we're seeing a big gap between male and female. That gap, again, is closing slightly and has been closing slightly over the couple of decades of data that's shown on this graph. And that shows that what we have been doing to try and improve these pathways, to introduce better screening, to do lots of different things to improve this picture, is starting to make a difference. But there's a long way to go. This mortality could be much lower, and the gap between male and female could definitely also be much lower. When we look at mortality rates in a little bit more detail, this graph again shows mortality rates by locality and shows massive amounts of variation. So Trafford has significantly lower mortality rates than the England average, and Tameside and Oldham have significantly higher mortality rates. When you add up Greater Manchester as a whole, you see that our mortality rates are higher, which again matches some data that we've shown earlier. So again, the message is that there's a lot more that we can do to improve mortality due to colorectal cancer in the populations we serve. Looking at those mortality rates by deprivation, we see kind of quite a stark trend. The two most deprived deciles have significantly higher mortality than the average. This again is data from, I think, national level, because we don't have specific GM data on this yet, but I'm sure it's coming. And looking again at England data for gender, we see very considerably higher mortality rates for men than for women. And then finally, just to complete the picture, as expected, you will see there's this higher mortality rate and lower survival for the most deprived. And that's kind of a very even trend looking across the deprivation quintiles within our population. So we're going to go into a discussion after the next presentation, so we won't ask for questions just now, but we wanted to just kind of sum up with a few things and suggest some things that we think are worth thinking about, given the understanding that we have about colorectal cancer within Greater Manchester. So we're seeing colorectal cancer as a big driver of health inequalities that has that really significant impact. I think it's kind of a month to 40 days shorter life expectancy just due to colorectal cancer between our more and less deprived areas in Greater Manchester. We're seeing white males clearly having the highest risk, particularly if they live in the most deprived areas. And so that is a really obvious group that we should be doing more to support in terms of improving screening uptake, which is crucially important, but also getting those referrals in and making sure that they're not afraid to come forward and report symptoms to their GP, and that we really believe them and go on to investigate when they do come forward. We need to work on mortality. We need to make sure that our pathways respond to those people. And we should be asking ourselves why the wait is longer for people from our more deprived areas and what we can do to fix that, particularly for that long tail of the very longest waiters. Given how important deprivation is for this situation, I've put up a bit of a map there to just give you the deprivation geography of Greater Manchester. And what you see there is that the darker areas, kind of central Manchester and the adjoining areas are our most deprived areas, with by and large the rural areas being more affluent. However, that is not a universal pattern. And depending which bit of the patch you're from, you'll see a different pattern of deprivation locally. So, thoughts? Does this reflect what you see in practice? Does this reflect what you experience in your role? I think we need to work together to think about what we can do to reduce these inequalities in cancer, what our main priority areas should be. And if you think there's data missing, then we've got our data colleagues here today. So today's actually a really good opportunity to ask for something if you think there's information we should have that we're not able to, well, that we haven't been able to present this morning. Thank you very much.
So thank you very much to Alison and Ben. A really thought-provoking talk there, and I think there's lots of themes there that we will be able to pick up in the discussion, which will follow shortly. So now I'd like to introduce Dr. Sarah Taylor, who is the Associate Medical Director for the Cancer Alliance for Primary Care. And Sarah's going to talk about lower GI referral pathways. Thank you.
Thank you. Right. Well, I've made a great promise on BBC Radio Manchester this morning. I was asked to go on to speak about the King's diagnosis and early diagnosis of cancer. And it was all going really, really well until they asked me, did I think the King should have, was it a bit of a shame that the King was being treated privately rather than on the NHS? I thought, oh God, I haven't prepared for this. I really haven't thought about this. So I said, well, it's not really for me to comment on what he's done, but I'd like to reassure everybody that the NHS treats cancer, takes cancer seriously and treats people well. And if you've got something serious the matter, or you've got concerns, you should come forward. So I've promised that we're doing it really well, which I think we are, but we have to stick to it now because I've said it this morning. So no pressure on everybody. So I'm lead for primary care and for early diagnosis at the Cancer Alliance clinically, and I'm a GP in Fallowfield. I'm just going to go through what we've done in terms of the referral pathways, just to try and improve things. It's a really difficult thing, isn't it? You know, there's Getting a GP appointment is not easy, but we want people to come forward with symptoms. We want to try and make things right, and we want to try and get the pathway as quick and as smooth as possible. And that first bit in primary care is absolutely vital. Just some stats and figures, which are quite difficult to actually go through and see because it's a slide. But actually, the bit on the left is just the number of lower GI referrals over the last year or so. And you can just about see, they've remained fairly static, but I think there's possibly a slight downward trend, which is exactly what I would be hoping to see with the introduction of FIT. It's not, and I don't know how this, and there's some data people in the room, how this compares with other pathways and whether there is a rise in other pathways. But actually, on lower GI, there is definitely not a rise, and there's possibly a slight downward trend, which is exactly what we should be hoping for with both FIT and the complete population coverage for non-specific symptoms, because I think that's an alternative pathway for patients with abdominal pain and this sort of thing. The bit on the right of the slide is just how quickly, and I know the 2-week wait is now not being measured, but it's actually the 2-week wait performance, which just gives an indicator of how quickly people are being seen after we've referred them from primary care. Bits in green show that people were being seen within 2 weeks. The bits in red are showing that they aren't. There's actually a slight improvement in that, although that's not uniform across all trusts. And I appreciate that there's a huge number of reasons for this. And I suppose that really we're looking at how we can work together as primary and secondary care to try and improve that and get people into the system quicker. I really like these slides. I think these are really useful for us. So this shows the early stage diagnosis we've got them for all cancers, and it shows where we rank in the country as an ICB. And actually, so you would expect that GM would be fairly low on some of these graphs because of our population. But actually, if you look at different tumour types, we're not the same in all tumours. So if you look at the lung, but the lung one, we're actually doing quite well in relation to other areas, and I think that's down to the lung health checks and the lung health checks having started earlier in GM. So although there's some bits of this I think we can't do very much about, and we're going to have to work very hard, there are bits and pieces that we can do, and I think working together like this and events like this just help to get us a bit higher up that league table. We're probably never going to be at the top because of our patient population and the difficulties that they have. But actually, I think we can work to get ourselves into a better position. And I think it's a really useful reminder of quite where we are. And I suppose we just be grateful that we're not in North East London. Normally it's Blackpool. Normally when they used to do things by CCG, and I was in Manchester CCG, I think there were 150 CCGs in the country, and Manchester would be 149th, and Blackpool was always 150th. So anyway. So what have we done? We have for a long time now had the same referral form across Greater Manchester for every pathway, and so that every GP refers into every trust with the same form. That means that form is agreed by the pathway board, and we make changes on their recommendations each year. Everything is compliant with the NICE NG12 guidance, because that is absolutely vital, and it's vital for our GPs as they refer in. All of these forms are integrated into GP referral systems, and we're working now on what we call clinical decision support tools. So they're built into the GP computer systems, so you can work through the guidance from the pathway board on any specific topic, to try and guide people to make as good referrals as they possibly can do, and to make it as easy as possible in primary care to do that. So if you type in, if I type in abdominal pain on a man in his 60s, it will say to me, you've typed in a symptom that might be suggestive of cancer. Do you want to look at the do you want to access the form? Do you want to look at the advice? It'll then bring up the infographic that you can see over there, and it'll bring up the colorectal referral form. It'll guide me through all of the questions. It'll give me the opportunity to print out any patient information leaflets and to work on that. I think there's a real... I would be lying if I said that there weren't some referrals that are maybe not perfect. And I think one of the we need to work together to try and improve that. One of the things I constantly say is that there's no point in me sending the same message out to primary care. I send messages out to primary care all the time, but there's no point in me sending the same message out all the time, because most of the people I send it out to are the ones most of the people who read it are the ones who already know. What we need to do is be targeting those people who haven't read it the first time, and working out which practices, which PCNs, which GPs are not following our guidance, so that we can work with them. Just reiterating the same message to the same group of readers really doesn't help, I don't think. So it's a real ask within trusts that actually, if you... There's not much I can do if I keep saying we're getting bad referrals, people aren't doing fit tests. I need to know who's doing it and how frequently they're doing it, because otherwise we can't work to improve things, because we don't know who to target. We do now have facilitators in each, well, they're not in each local, but in most of the localities in GM, who will be going out and working with PCNs, and that'll be one of their roles, to say, you know, you're not doing fits with these patients, you're not filling in the mandatory questions, all of these sorts of things on the forms. And so, but if we don't know which PCNs and which practices are not doing that, we can't target. And we'll be speaking to people who'll say, well, we're already doing that, why are you telling us again? We have got what we like to call our mandatory questions on the forms, which, apart from in Manchester, CCG area, locality, are not actually mandatory, but they are the things that you really constantly ask us to make sure that people are filling in. So does the patient know they're on a suspected cancer referral? What's their frailty status? You know, are they on metformin? Are they on anticoagulants? All of these sorts of things. Again, we do try and encourage people to fill them in, and the clinical decision support tool, if people use it, will guide them through filling it in, but we can't actually make them mandatory, much as I might like to do so. Fit, they can't be, I mean, there could never be a lower GI meeting where you don't spend most of your time talking about fit. Have you got your, yeah, Roger's got his fit. The nice guidance is, as everybody I'm sure in here knows, that patients should only be referred on a lower GI suspected cancer pathway if they have a positive fit, anal or rectal mass, or anal ulceration. That's the way around it is. There's a real incentive, there's real encouragement, pressure, whatever you want to call it, in primary care to do this. The IIF has now changed its indicators to reflect patients having a positive, only being referred with the fit result. So that helps, because it basically pays GPs to do the right thing, which is a good way of actually encouraging them to do it. There is some talk, we don't know quite what's going to happen to that after the beginning of April. There's some talk of that being, at the moment it's done on a PCN basis, and the payments that GPs get to their PCN, primary care network, rather than to the practice. There's some talk about it switching to a practice-based payment from April onwards, which I personally think would be better, because I think there'll be more ownership of it within practices. But the incentive is there, and goodness knows we've done enough to try and encourage people and tell them what to do and ask them to do it. And I'm sure that, Lauren, how often do we, every time we do a PCN call, we talk about fit. Anytime we've got even half a GP in a room, we talk about fit, and we will carry on doing so. Having said that, you know, we've done reasonably well, but there's still quite a lot of room for improvement. And I think that this table, which again is a little bit difficult to see because of the size of it, just shows the number of referrals that are coming in with a fit across GM. I think the most important, the rates are going up, which is good. I think the most important thing for us, from a primary care team point of view, is the variation between localities. We're going to doing incredibly well, and some of the other localities aren't doing quite as well on that, and we just need to work out what's working in one locality, whether it's just that they've only got one PCN that aren't doing it, or one practice, all of these. So we just need to work really hard to do this. The other thing that, in defence of all of my GP colleagues who might send things in, there's a real issue at the moment, isn't there? Because there is no option for us, really, apart from refer to A&E, 2-week wait, or wait for, well, probably 12 months plus. There's not much in way of urgent referrals. One of my colleagues the other day was saying that they'd referred a patient with a really high fecal calprotectin, symptoms, very strong symptoms of inflammatory bowel disease, and have been told they can't be seen for 6 months. And that's just really, really difficult then. So you can't blame people if they've got a sick patient. Do you send them to A&E? Do you do make them wait 6 months when they're really poorly, or do you do a 2-week wait referral? It's a really difficult situation, and I don't know quite what we do to solve that. And I think it's, but I think that is, if we want to manage 2-week waits, no, they're not called that anymore, sorry. But if we want to manage suspected cancer referrals, we need to be giving primary care an alternative for those patients where they're really not worried about cancer, but they are worried about the patient. And I think that is still something that we haven't got nailed across GM. This is our pathway forfeit, which is quite clear. It's been agreed in conjunction with the pathway board, and it's quite clear to everybody in primary care what they should be doing. The important bit, I think, as well, is that we do have that facility for patients who have persistent symptoms but not colorectal symptoms to be referred on the NSS pathways, and I think we are really lucky. I think looking at other areas across GM, across the country, they don't have full population coverage for non-site specific symptoms, and all the evidence is that most of those patients, if there isn't NSS coverage, will come in on a lower GI pathway. So I think that will makes a bit of a difference to what we are able to do locally. And we are, and Becky's talking a bit later as well, but we are continually trying to encourage referrers, if they've got a concern and they've got a negative fit, to think about an NSS pathway. Just a little bit about what we've done on engagement. We do webinars. We've done quite a lot of face-to-face primary care education events. We've done some work nationally. We've got an event coming up in a couple of weeks' time for practice admin staff, where we're talking them through one of the sessions, because we like to talk about fit a lot, is entirely about fit, so that the practice staff know how to, if a patient comes in and said, then the GP wants me to do this test, can you, they've left a sample at reception, they can talk them through exactly how to do it. I know from some of the colleagues in the labs that there's still a big problem with patients overfilling the tubes. There's a problem with samples not being labelled. What we're hoping is that if we can educate our practice admin staff as well, that we'll reduce some of those issues and that we'll get fewer samples returned, because that is another delay in the pathway. The number of, it does still, I don't know how much poo people think they need on these sticks, but the number of overfilled samples seems to be huge. Anyway, we've got texts on the system, so you can text a patient on the day that you ask them to do it, saying that this test is really important, please do it, and attached is some information on how to do it. And then we've also got that then instigates a text 3 days later saying, if you haven't done it, this test is still really important, please do it, a reminder of how to do it. We've got all of the infographics, and because we've got one on lower GI cancers, we've got one on FIT, we've got lots of different ones. And we do webinars, face-to-face events, and various other things. And we've also working with Anna and the rest of the comms team on making sure that we've got as much patient information in the right formats to try and support them to come in. And what I really want to do is work on some of that and with practices on that next step, because I think it's all very well having that information that you've got a symptom of concern, but you need to have and what do I do with that next, and how can I do something? I think one of the things that I've been quoting for years is that the woman with a breast lump who comes to reception is perfectly happy to say to the receptionist, most of them are happy to say, I've got a breast lump. The receptionist, who's often female, will go, that's a bit worrying, I'd be worried if I'd got one. And they'll be in my clinic that morning, which is absolutely fine. I don't think we've given our patients or our practices quite the same strong link for other symptoms of concern, persistent cough, weight loss, change in bowel habit, all of these things. I don't think we've got quite that same thing there for them to have that power to get the appointment that they need. And I think we need to be, I think then, I don't know whether that links into some of the issues in the previous talk, that actually to be able to advocate for yourself is quite important. I think women are able to do that with breast cancer symptoms. I'm not sure we've got all our patients able to advocate for themselves quite as well with colorectal symptoms, and I think that's something else we should work on. And I think that's the end. I don't know whether I've done that in anything like the right time, so I'm sorry. I think I might be a bit quick.
Great, and thanks very much, Sarah. That's a really clear description of some of the successes and also many of the challenges that we face. I was going to invite you back up, but you're on your way. That's great. So I think, so now we move on to the discussion part of this morning's session. I think we should have some roving microphones for members of the, brilliant. So are there any questions anybody wanted to ask? Okay, so, oh yeah, okay, we've got a question over there at the back. Thank you. Thank you for being the first person to ask a question. Excellent.
Thank you for the excellent presentation. Really enjoyed that session. So from an oncology point of view, we tend to see more and more young patients coming through our doors. I'm not sure what your data around GM. You see this kind of influx of new patients. Now it's 10% of the population we are taking at prestige with chemotherapy, but I think it's many more because a lot of them will not be referred to us. So I think there is a lot of work to be done around that, because for me or for oncologists, this is a tsunami coming. And also, what in the front door of GPs now, how aware are you of this phenomenon, and how are you planning to address it, both from public health but also from a primary care perspective?
Sorry, you're asking, can I just clarify exactly what you wanted to add?
So it's about the data that you have about in GM, about early onset colorectal cancer. What is the policies from public health perspective that you try to implement to tackle this phenomenon? And also from primary care, if you are aware of this, and how you address it, because we have a lot of young patients coming for 3 or 4 months with symptoms that they are not considered as could be cancer, also this minority, but still 10% of these patients coming through.
Yeah, I think from the primary care point of view, particularly the young patients are something that are quite worrying, aren't they? Because there's an increased number of young patients, and the NICE guidelines, which I think are just about to be, I think all the NG12 guidelines being reviewed, are actually very, very age specific, which I think is a bit of an issue and a bit of a problem. What we've done, firstly, I think that FIT helps with that, because I think that from a primary care point of view, if you've got a patient with worrying symptoms, if you have to think about, do I send them on a suspected cancer referral or not, or do I ask them to do a FIT test or not, that's a much, much easier decision from our point of view. And I think that most of my colleagues are now, and I suspect that there's some colleagues in the room who can reinforce it, are actually have a much lower threshold for doing a FIT test on a young patient with concerning symptoms, which I think is probably the right thing to do to try and get more patients into the system. And also, just in terms of our clinical decision support, what we have done is we've got the triggers for lower GI cancer at 30. And so it does say, if you type in altered bowel habit, and the code comes up at the age of 30, it will say, would you like to see our guidance?
So we've got to strike a really important balance here, because we are seeing more young presentations, absolutely, but we also know that it is still absolutely true that cancer, the biggest risk factor for cancer is age, and that's absolutely the case for colorectal cancer as much as it is for any other. So we have kind of a few different things we have to do in response to that, to address that balance. We have to keep collecting the data. We have to keep interrogating that data and understanding that the picture that we're seeing will always move, and the things that were the right response to that data 5 years ago might not be the right responses to that data in 5 years' time. Our screening programme has an age threshold that's in the right place for what we believe to be the epidemiology of the cancers that are out there, because most bowel cancers will occur in that older age group, and it's not cost effective to screen a much younger population. That means we're more dependent on that symptomatic pathway for picking up the younger cancers than we would be for people who are within the screening age. And that means it's really important that that pathway, using the FIT test, as Ali mentioned, works really well, and that we promote messages that are clear, that bowel cancer can affect younger people, that bowel cancer symptoms have to be taken seriously, and that if you present to your GP with those symptoms, you will be taken seriously. We'll give you the investigations that will help us narrow down why you've got those symptoms, and make sure that we can support you appropriately.
Thank you. Important balance there between not missing young patients with cancer, but not investing too many resources in an area of population that are at low risk. Yeah, thank you.
Thanks very much, Steve. First of all, thanks, Alison and Ben. That was a fantastic presentation, a great overview to start this meeting. And thanks for all your help with the work, what you guys have done with you looking at the inequalities. What I didn't see in your presentation is anything to do with money, because that is the only thing which talks. Yes, there is a huge variation, but if you say there is about 10%, 20% variation, yes, but it doesn't make much to the politician. Whereas if you say that, that equates into so much of increased mortality, increased economics from the pounds spent on each patient, that always carries more value. Is there any evidence in the literature to suggest that if you are deprived in this, so like what you showed about the percentiles, then they have the resources spent on these patients because they present late, they have high comorbidities, they die early after treatment or without treatment. You're spending a lot more resources on them. Is there any evidence on that, please?
Thank you for that question. It's a really good question. I haven't seen that data, but I think it's something that I would definitely be willing to have a look at and discuss with you at a future opportunity. Have you seen anything on that, Alison?
Yes, similar, really useful point. I haven't seen the specific data, but yes, definitely worth us having a little look and investigating that further. Yeah.
Okay, thank you.
My question was pretty much tied with Selma's question, actually. You have the most deprived population having cancer or high risk of developing cancer, and then we know on average, as you said, 2 to 3 days to see a GP to be able to get them investigated. What are we doing in terms of investigating resources to be able to make sure those population group gets targeted and gets to see a GP or get to do the fit test earlier to be able to have a different outcome? Have you analysed the reason behind it? Is it the accessibility issue with the GP? Is it because they don't go because they're not well aware about it, have to go with those symptoms and all that? Or is it just the issue with the money that we're not able to put in, around money into that sort of population group or that area to be able to target these specific?
Yeah, I mean, I think, like you say, it is a multifactorial issue. I think we know that some populations are less likely to access the screening tests, like you say, and we've just done some really interesting, as I said, behavioural insight work looking at the reasons for that around colorectal cancer in particular, sort of cancer screening, but also specifically on colorectal cancer. So things like for colorectal cancer specifically, that our issues are around knowledge about the screening test. It seems to be a big issue compared to some of the other screening programmes, which are much more well known, but also the sort of barriers around actually doing the test. So people feel like it's messy, or it's sort of worries about doing it properly. So there's sort of inequalities with access to that screening. And then also, as you say, inequalities in people's knowledge of the sort of early diagnosis symptoms, and also barriers then to accessing help. So I think it's across that pathway.
There's something particularly in men about that help-seeking behaviour, about men who might have had relatively limited contact with their GP. They feel like they're a stranger to them because they haven't gone through that maternity pathway, which often brings women into much closer contact with health services. So we have a bigger job to do to encourage men to check for symptoms and to come forward. We have a bigger job to do to encourage people from Asian ethnic groups to come forward, because they probably know fewer people who've had bowel cancer, if the statistics tell us anything. We definitely have a much bigger job to do to give people in our more deprived communities the confidence to come forward with symptoms. When we speak to the public, we hear all sorts of different narratives as to why people don't come forward. They might think it's nothing, that it's not significant, that it doesn't mean anything. They might think that the symptom that they've noted is just, part of getting older. They might think that people will ignore me if I do come forward. They might think that all sorts of different things about what will happen, and they might be fearful about what would happen. And we've made a start in Greater Manchester on addressing some of these things. We've done some interviews, we've done some work to understand people's perceptions. We've had the Greater Manchester Bowel Movement a few years before the pandemic, which attempted to kind of start a bit of a conversation about bowel cancer and those symptoms that people need to look out for, and to kind of demystify things. And I think there's a lot more we need to do through communication and engagement with the public and our patients to really address this challenge. But we also need to work with primary care. We really need to make sure that everybody who's part of that primary care pathway, from the GP receptionist to the person who codes the GP website, to the person who will see that GP, that patient for a consultation, which might be a GP or another practitioner. We need to make sure that along that entire pathway that people are taken seriously, that we have an empathetic response and a supportive response, and that people have a good experience of the first time they question what might be a non-specific symptom initially, so that they then come back if they've got further concerns later on. And so we've got to make sure that we balance what we do, where we invest. We've got to get screening right, but we've got to get the symptomatic pathway right as well. And they're both incredibly important.
Thank you, Ben.
Hi, that last point you just raised about the asymptomatic pathway and the symptomatic pathway is what I was going to try and raise. We know that the asymptomatic pathway uses a different cutoff, for example, and we know that it could be lowered. So England, compared to the rest of Europe, uses a much higher cutoff. Is there any scope to lower the cutoff so you can get more patients that way? And another key point is, what proportion of patients referred for colorectal cancer are picked up by the asymptomatic pathway and by by patients with symptoms? Because obviously, if the asymptomatic pathway can pick up more, can you try and use that pathway more? So by lowering the threshold, by targeting certain populations more, by giving people more fit devices rather than every year or however it works. I'm just thinking, have you thought of that or tried that?
I'm just going to see if we can quickly whip back to the slide that covers this question. I don't know if the computer...
And can also make, whilst you're doing that, a quick point. Fit tubes are really hard to label. They're absolutely tiny. So when Sarah said about patients, I think it's about 5% don't label them. It's really hard to label them, so I'm quite sympathetic, actually.
Absolutely. So this is the chart that I think talks to the question you're asking. It looks at all of the cancers, colorectal cancers, that are diagnosed, and it's split out. The different coloured bands are deprivation quintiles, but it's split out by the pathway and how people presented which pathway they come through. What you can see is that screening is a relatively small proportion. Around 10% of the cancers we're picking up. So the vast majority of cancers are not picked up through screening. But screening is really important because those are generally the 10% that are going to be pretty early and that we're going to be able to get really good outcomes for in treatment pathways. The 2-week wait, or whatever it's now called, I'm obviously not up to date on that, picks up the biggest group, so about 40%, something like that. But emergency presentation picks up a massive number here. And this is almost the catch-all. This is almost what happens if we don't find them when we want to find them. And what a really well-functioning pathway would see more being picked up through this 2-week wait and other GP referrals, fewer emergency presentations, and potentially more screening pickups. We have a national committee called the called the National Screening Committee, which looks at questions like what the fit detection threshold should be. And what they will do is they will use the data and research that's being conducted and the registry studies that are continually conducted to evaluate that question and understand for the UK's population what is the optimal level to put that screening threshold at. Essentially, if we lower that threshold, we're going to do more investigations that turn out not to be cancer and worry more people, because that you might have cancer, you probably don't, but we need to have a look at it message is a really worrying one. And we have to trust their expertise in a way to get that threshold right. But what we have the power to do really in Greater Manchester is to get that one up by making sure that more of the people at higher risk get screened, because one of the obvious things that jumps out of the data for me is the people who get screened are generally the people at the lowest risk of cancer. The people who don't get screened are often people at higher risk. And so the more we can ramp up that screening uptake, the more we'll skew this graph to that end. We also need to make sure that people who are at higher risk are happy to come to their GP and get that referral. And yet again, you've got this pattern that the people who are at highest risk are least likely to present to their GP with early symptoms and to get that onward referral. So there's those real inequalities, and if we can speak more loudly, more confidently, and engage properly and understand people's concerns and respond to those concerns about coming to a GP or about screening in those groups that have the lowest, the worst outcomes, then that's probably how we start to shift these numbers. Does that answer your question?
I just missed it when you did your talk, sorry.
Don't worry, it's a really busy slide. Thanks.
Can I just add a little bit there? I helped establish the bowel cancer screening programme in the North East sector of Greater Manchester back in 2007, 2008. So I've lived with the bowel cancer screening programme over the last sort of 20 years or so, not quite that long, sorry, 15, 16 years. And the reason that the fit threshold is set at 120 at the moment is entirely arbitrary, and that is just so that we get the same percentage of positives as we used to get with the old rubbishy guaiac-based FOB test on the 3 scrapey bits of cardboard, which was, if you think the fit test is difficult to label, the old FOB test was a nightmare to do. But people did it. So we had to, when we introduced fit, we had to promise that we'd get the same number of tests coming through positive as we had with the old system, so that we didn't overwhelm screening. Because the risk, if you do overwhelm screening is you undermine the reputation of the service. You say to somebody, you know, you had no symptoms, you took a chance, you did the test, we can't now do your diagnostic and give you an answer for 6 months. That would be completely unacceptable. So it's set 120 just for that reason. And the intention nationally with screening is to increase the age range before we bring that fit threshold down. So if I think back to when I first started doing colonoscopy screening, we did 2 lists a week in Bury, and we sometimes didn't fill them. When we age extend down to age 50 by the end of this year, or beginning of next year, we should be having 13 lists a week, which is a whole endoscopy unit, more than 2 sessions a day, just for bowel cancer screening. So we will get more and more people to the left of Ben's graph there. And that's really important, as Ben said. In screening, we are used to diagnosing stage 1 to 2 cancers. Those emergency presentations, each of them is a disaster. And in each of them, something's gone wrong. Either through lack of public awareness, lack of confidence in approaching our health service, or a lack of awareness in terms of what we do for what those symptoms mean. And to me, for a disease that can take 20 years to develop from a cell turning into a polyp and a polyp turning into a cancer, for somebody to present with obstruction as a symptom of their bowel cancer is just appalling. And we really need to work really hard to do everything we can to shift everything to the left on that graph. And what's going to come next is a fit threshold at some point will come down to 80 in screening. And that's going to be piloted by NHS England. And NHS England are quite impatient in getting on with that. And they want some centres to pilot that as early as next year. So it will gradually come down. And what I'd like to see over time is a convergence between the symptomatic service and the screening service. The standards, the quality, should at some point be indistinguishable. And then we've got things right.
Thank you, Roger. Any other questions? Yeah.
Touching on the awareness part, where can we access that courses, the leaflets, everything? Because we do quite a lot in the community, and you know, we touch on like the Wigan Warriors, the Wigan Athletics, the local clubs. We would like posters to put up in the toilets, on the walls, on the notice boards. Where do we access them?
There's quite a lot of stuff on the GM Cancer website. If you go on there, I think Alison's here, isn't she? I saw her outside. But there's a lot of resources on the GM Cancer website. There's loads of stuff on fit, how to do the fit in every language known to man, pretty much. And so there's lots of stuff on there.
So can we print them off?
I am not sure. I can't see.
I think it is a problem with education and awareness.
Yeah.
But you never see a bowel cancer poster anywhere, or this is what to check for. And I think that would help.
Right, okay. Well, I will speak to the team and make sure, but I'm sure there's definitely stuff on the website. I'm almost certain it's possible to print it out. And we've also done some work that we need to pick back up again with AskDoc, who will do videos in different languages as well, because obviously the reading age in different languages is different, isn't it? And sometimes spoken word is better. So we have got some audio as well on there.
Great, thank you.
Hi.
Oh, sorry, the microphone's just behind you. If I come to you next, is that okay?
Hi, I'm Amanda Coop, one of the CNSs from the Christie in Manchester. Thank you very much. It's been a really interesting debate. My interest is in regards to the health inequalities. What are we actually doing in schools with children? What's the education they get at secondary and at college and universities? I think this is where it needs to start. And, you know, I don't know what is out there or what's being, you know, discussed in local schools. Is anybody aware of that?
Yeah, it is a really good point. I'm not aware of work in schools. I don't know if you are, Ben.
So, the national curriculum, including biology, does cover some material on cancer, but it, as far as I'm aware, is not a topic that's centred on in kind of personal social education or whatever acronyms used to describe that service right now. So it's not really there. And one of the challenges that we have when we try and work with schools on public health topics, which we do a fair amount of, is that the proportion of the school day that can, or even the school year that can be spent on public health issues is constrained, and what we try and do is to prioritise the things that are most relevant to children at that stage in their life. So it gets missed. And I think that means that we end up having to try and communicate with people as adults about this topic when you're really competing for people's attention because they're not, you know, sat in a classroom forced to listen to you. So it's a good point, and it's a real challenge that we have to overcome.
Thank you. I think we've got time for, we've got two more questions. So one here and then just one at the back there.
Thank you very much. That's been a really useful session this morning. Mine was just a really quick question to either Sarah or Roger. Do we know how long a negative fit is valid for? So if you have a negative fit 6 months ago,
I think it would depend on the patient and the symptoms. So from my point of view, if I saw somebody, obviously like every test, it's not 100% reliable. So if I saw somebody with a negative fit whose symptoms persisted, then I would need to think about what else might be causing them. So if it was a purely bowel symptom, such as changing bowel habit, then I would occasionally repeat the fit, although I'm not sure I've actually personally ever done that, or make a referral on an urgent routine pathway. If it's a non-specific symptom, such as abdominal pain, then, and I had persistent concern, then I would very much think about referring on the non-specific symptoms pathway. I think that, you know, it's one of the reasons that we spend, if we talk about fit a lot in our GP education, we talk about safety netting almost as much. And I think that safety netting and making sure that you follow up patients who have asked for, who you've asked to do a fit, to make sure they do it, to make sure the result is dealt with, and to make sure that they know to come back if their symptoms haven't settled is a really important part of the process, and one that we keep reiterating to primary care.
Thank you. And final question.
Thank you. I'll keep it brief. I just wanted to take the opportunity to promote the cancer screening improvement leads that Greater Manchester are very lucky to have. So there's 3 of us. We cover the whole of Greater Manchester. We're based in the bowel cancer screening programme. So my name's Nova, I work in the Bolton screening programme, covering Wigan, Salford and Bolton, of course. Caroline, my colleague, she's in the Pennine screening programme, so she covers the north part of Greater Manchester, Tameside, and we've also got a colleague who covers the more south parts of Manchester, so Trafford, Stockport, etc. We're based within the bowel cancer screening programmes, but our primary aim is to increase uptake and awareness of bowel cancer and bowel cancer risks and symptoms. So a large proportion, going back to a colleague here about promotion, is we do a lot of work in primary care, so we're the guys who you can come to for links for resources and what you can stick up in on the back of your loo doors and things like that. But we also do a lot of promotion out in community, and we work with colleagues, charities, but we also try and get into all those places. We're doing a lot of work with employers, primarily kind of male employers in the area. We do talks. I haven't done schools as such, although I've got a couple of high schools coming up. But I work quite closely with the health and social care college students, try and bring them into the hospital, let them have a visit around the endoscopy unit, etc. So there is stuff going on. It's just that obviously there's 3 of us for 10 localities. But please make sure we've got a couple of posters up on the back, but certainly our contact details are on the one that I've produced, which is about the effect of how screening has affected the colorectal pathway. So please get in touch if there's anything. I know it's not a question as such, but I just wanted to...
No, thank you for that.
Just wanted to get up there.
That's really important work, and thank you very much. So thanks everyone for all those really, really important and interesting questions that have really provoked a lot of thought and a lot of discussion and debate. I'm going to hand over to Roger to close the session now, but before we do that, I would just like to give a final thank you to Alison Pye, Ben Fryer and Sarah Taylor for excellent presentations this morning. Thank you.
Thanks, Steve, and thanks for expert chairing. We've run exactly to time, which is extraordinary. And thanks to everybody for the questions, the engagement in that session as well. It was absolutely brilliant. Reminded me of when my son was in primary school, and parents were invited into school to talk about what they did for a job, and I took a scope into school, and they didn't invite me back. So we're going to break now. We're going to come back here at 11:45 for the next session, and I'd just like to thank you all for your attention. Just another round of applause, particularly for Steve, expertly chairing that session. A great start to the day.